Hi, everyone. My name is Priya Deshpande, and I'm an onconephrologist at Mount Sinai Hospital in New York. I'm here with Dr. Meghna Eswarupa, and she is a first-year renal fellow at the University of California at San Francisco. Meghna and I are very excited to be here with you today for this NephRworldCup.
So this segment focuses on the association between chronic kidney disease and renal cell carcinoma. Priya, can you describe this association?
Of course. So let's first tackle how chronic kidney disease is a risk factor for renal cell carcinoma. Recent observational studies have placed the risk of renal cell carcinoma in end-stage kidney disease between 3 to 7 times that of the general population. This increased risk of renal cell carcinoma is associated with chronic kidney disease and low glomerular filtration, indicating that the kidney disease exerts a specific localized carcinogenic effect on kidney cells.
That's really interesting. How does that happen?
So at this point, it's not really clear, but several pathways have been postulated to play a role. And these pathways includes derangements in DNA repair, carcinogenic uremic toxins, and oxidative stress. For instance, a patient with diabetes mellitus and obesity may have an increased metabolic load in the proximal tubule, and the resultant damage can cause renal cell carcinoma. Also, in terms of molecular mechanisms, there may be a link between kidney injury, acquired cystic kidney disease, and papillary renal cell carcinoma through the Notch1 pathway. Other risk factors include male gender, older age, end-stage kidney disease due to obstruction, and focal segmental glomerulosclerosis. Regarding acquired cystic kidney disease, this can occur in patients with advancing chronic kidney disease and end-stage kidney disease. And it's been postulated that acquired cystic kidney disease can progress to adenomas, which can then result in renal cell carcinoma.
Wow, so how does this association play out in patients with a kidney transplant?
That's a great question. The risk of native kidney renal cell carcinoma in transplant patients is decreased compared to patients on dialysis, but still that risk remains 42-fold higher than the general population. So there's a lot of room for further research in this field, but what's particularly interesting to me is how renal cell carcinoma is a risk factor for chronic kidney disease. Meghna, I'd love to hear your thoughts about this relationship.
Definitely. So this association is particularly interesting because the tumor as well as the treatment can both cause CKD. So first off, CKD and RCC have many shared risk factors such as hypertension, diabetes, older age, and tumor properties such as size and stage have corresponded to reduced preoperative kidney function. In fact, in one study of over 1,500 preoperative patients, parameters such as increased tumor size, stage, and histology, particularly the papillary subtype, correlated with a higher baseline CKD stage. This was likely from higher tumor burden and decreased functional nephrons. Also, many patients with RCC who underwent either a partial or radical nephrectomy were found to have interstitial fibrosis and tubular atrophy on evaluation of their non-malignant renal tissue.
Oh, that's really interesting. So a lot of patients don't even know that they have chronic kidney disease or proteinuria at the time of surgery. So then how does the surgical interventions impact kidney function in patients with renal cell carcinoma?
Happy to talk about this. So recently, nephron sparing procedures such as partial nephrectomy have been increasingly favored over a radical approach, particularly for tumors less than 4 centimeters. The risk of AKI after partial nephrectomy ranged between 20 to 34%, and after radical nephrectomy was about 30%. And patients with baseline CKD are at a high risk of kidney function decline after surgery. And new onset CKD, defined as a GFR of less than 60, has been seen in 30 to 50% of patients undergoing a partial or radical nephrectomy. In the operative time course, longer ischemia times can result in lower immediate kidney function, but their effects on long-term kidney function is debatable. And loss in functional renal parenchyma during surgery also causes a decline in kidney function. Post-operatively, additionally, a patient's course may be complicated by AKI, which can also contribute. And let's not forget that the acquired solitary kidney itself is at risk for FSGS as a result of compensatory hypertrophy and hyperfiltration.
That's a really succinct review of how surgical treatments of renal cell carcinoma contribute to chronic kidney disease. Many of these patients require medical therapy after a partial or radical nephrectomy. In recent years, the first line of management for metastatic renal cell carcinoma has been immune checkpoint inhibitors, either alone or in combination with tyrosine kinase inhibitors called TKIs. The tyrosine kinase inhibitors can also be used alone as well. Meghna, how do these drug classes affect kidney function?
So that's a great question because checkpoint inhibitors and tyrosine kinase inhibitors have revolutionized cancer care, but unfortunately, both classes are known to cause renal pathology. Checkpoint inhibitors, which include ipilimumab, nivolumab, pembrolizumab, and nivolumab, have been shown to cause acute tubular necrosis and acute interstitial nephritis. And in really rare cases, they've been shown to cause focal segmental glomerulosclerosis, IgA nephropathy, post-immune glomerulonephritis, and C3 glomerulopathy. The incidence of AKI with CPIs is between 2 to 5%. The TKIs, which include sunitinib, axitinib, sorafenib, pazopanib, and cabozantinib, can cause TMAs or thrombotic microangiopathy, which presents as hypertension, proteinuria, and TKI.
So as you can see that there's a bidirectional relationship between renal cell carcinoma and the treatment and its treatment causing chronic kidney disease and chronic kidney disease causing renal cell carcinoma. You can see on this slide here that we have that many of the similar risk factors for developing renal cell carcinoma and chronic kidney disease are the same. For example, high blood pressure, diabetes, obesity have all been implicated in both of these disease processes. So I think as a result, we need to have an interdisciplinary approach between the nephrologist, the urologist, and the oncologist in order to help better take care of these patients. So that's it for our segment today. And I thank you very much for having us.